Hello, and welcome to our presentation on our paper, Queering E-Therapy, Considerations for the Delivery of Virtual Reality Therapy with LGBTQ2IA+ Communities. Concerns regarding mental health have never been more important, particularly within the current context of the global pandemic. A review of existing literature argues that queer youth and adults are particularly vulnerable to negative mental health and are more likely compared to the general population to experience challenges around their mental health. Despite recent advancements in healthcare and the growing recognition of mental health, queer adults remain at risk due to a variety of social, structural, and behavioral barriers. Barriers including a lack of queer knowledgeable healthcare professionals, high costs, and past traumas. As you can imagine, these are but a few of the barriers that result in limited access to adequate care. Adding in the complexity of the global pandemic, digital mental health services have emerged as candidates to assist in addressing these concerns. Digital mental health services have long since been investigated as a means to address the adverse effects of poor mental health, thanks to the rise of recent interventions like video conferencing and online counseling. These tools include video conferencing like Zoom and Jane.app, online counseling and therapy like BetterHelp and Talkspace, and mindfulness applications like Headspace. There is now a pursuit to investigate emerging technologies, particularly virtual reality or VR's feasibility as a user interaction model for digital mental health interventions. VR can be considered an umbrella term entailing real-time presentations of a computer-generated environment to a human user. Users experience and perceive these environments through multisensory stimulation, which in turn can trigger real emotions and physiological symptoms like an increased heart rate. Growing interest in the area partnered with decreasing costs of hardware and increased availability of open access software systems serves as a basis for this technology to be explored further as a therapeutic intervention. More specifically, however, it is needed to address the feasibility of VR for addressing community-specific needs, such as the case with the queer community. This study seeks to explore the needs and wants of both queer adults and mental health professionals with digitally based mental health interventions using a human-centered approach. We do this by addressing the following two research questions. What is the experience of modern digital health mental tools for queer adults and mental health practitioners? And what do queer adults and mental health practitioners think about the use and implementation of clinical VR as a tool for mental health services? The aim of this study is to explore attitudes by queer adults and mental health practitioners regarding clinical interventions using VR technology. We hope to identify barriers and opportunities, highlight service gaps, and identify good practices in addressing the mental health and well-being of queer adults.
Now we'll jump into the methodology. We distributed two unique surveys using the Qualtrics platform. The surveys had short answer, multiple choice, and ranking questions that ranged from 32 to 38 questions, depending on the logic and the survey. We included individuals who were 18 to 65 years of age, who were English fluent. And for the first survey, we distributed it to queer individuals who may or may not have previously used mental health services. And for the second survey, we distributed it to registered mental health professionals. We recruited participants through online special interest groups, such as the Queer Design Club, Psychology Today Canada, social media, word of mouth, and snowballing techniques. The survey questions explored experiences with mental health services, experiences with digital mental health services, and the interest and necessary requirements for VR technologies for providing and receiving digital mental health services. We analyzed our data using a thematic analysis over Excel, coding the data, and also using the Miro tool to collaboratively analyze our qualitative survey results. Looking at the results now. The demographics for mental health professionals included individuals who were approximately 26 to 45 years of age. They identified as white, Caucasian, lived in Canada, and they were generally women who had no transgender history and had a sexual orientation of straight. Looking at the demographics for the queer community, we had participants ranging from 18 to 35 years of age. They identified as white or Caucasian, mainly lived in Canada or the USA, and they had a gender of man or woman with the exception of one gender fluid individual, and they had generally no transgender history with the exception again of one participant. And looking at the sexual orientation, on average, the participants were gay or homosexual, and we also had individuals who were bisexual, lesbian, and queer. Now looking at the barriers of digital mental health services, queer participants identified barriers such as cost, limited availability, lack of queer-friendly resources, and accessibility of digital mental health interventions. While looking at the mental health professionals, they indicated similar barriers with the exception of stigma from families and friends and lack of culturally sensitive representative resources. While looking at the use of digital mental health services, queer individuals generally use mental health services due to the recommendation of family or friends or the required shift to COVID-19. Similarly, mental health professionals use the mental health services due to the required shift online due to COVID-19. The use was ranged from daily, weekly, biweekly, or when they need it via a mobile device versus a desktop computer or laptop. The digital mental health services used by mental health professionals were mental health questionnaires, video conferencing platforms, and telerehabilitation. They use these tools daily or weekly with clients. Now looking at VR use, most queer participants had previous experience with VR technology, but for the purposes of entertainment, such as digital gaming. While looking at mental health professionals, most did not have experience using VR to use for providing mental health services, although one participant had previous experience using VR for exposure therapy to simulate experiences such as phobias.
We will now explore conversations with our participants surrounding experiences with digital mental health services and the themes that arose. Topics surrounding simple delivery came up that concerned with simplicity, consistency, and being easy to navigate for those with cognitive barriers and or low technological literacy. Participants discussed topics of flexible use, particularly with the idea of a multi-use tool with different features from scheduling to forms and appointment scheduling and to be used on multiple devices. Topics about seamless interactivity had considerations for poor internet connections and service provider barriers and privacy. Participants discussed personalization and the importance of personalized experience with agency and control, progress tracking for personalized goals, and options to interact in unique styles, such as with camera on or off, or over the phone or online. Participants also discussed patient and provider support. This concerned services and providers being properly informed on queer healthcare and reflecting the client's ethos with topics like feminism and secularism as examples. They also discussed the importance of being properly educated on queer topics and gender sensitivity in a way that wasn't condescending. And also it was important that clients are supported through compassion and empathy to encourage prolonged use. Participants also discussed VR as a tool for digital mental health services. Topics about low cost, concerned with the cost and tech availability as barriers to VR for queer people, with 10 queer participants still highlighting an interest in the use of clinical VR, however. Participants discussed research, training, and education, and how VR can be perceived as a niche technology that several queer participants highlighted a lack of familiarity towards. Mental health practitioners required more evidence-based research and training for VR-based digital health services. Queer participants highlighted aesthetics, calming audios, and visuals as being key for engagement and realism concerning the topic of usability. Mental health practitioners worried about a complex implementation that should instead require limited steps and an overall high efficiency of the tools. In discussing safety and privacy, 2 participants shared concerns regarding safety regarding undue mental influence and motion sickness. Data privacy was also a concern for 3 queer participants, and extending that concerns to digital mental health tools overall, not just in VR. When discussing immersion, immersive qualities of VR were particularly attractive for participants as it was something that current mobile-based services lacked. Several participants highlighted the potential VR would have for circumventing social barriers put in place by the reliance on those screen-based systems. And finally, when discussing provider control and customization, this covered topics such as allowing queer clients to control where their avatar could be in relation to a therapist or counselor, giving both the client and the provider the ability to customize the experience to the individual needs and desires, and the potential for allowing the mental health practitioner to help guide the patient through the experience, offering a greater sense of safety, particularly for exposure therapy when used for phobias.
So as a quick recap, we explored the current state of digital mental health tools, particularly with VR systems, and how it addresses the needs of queer adults and mental health practitioners. In doing this, we have highlighted some design considerations, which we believe can specifically address the unique psychosocial stressors which are faced by queer adults and which prevent them from seeking mental health care services. Let us now offer a brief interpretation of the findings. Mental health practitioners converted to offering mental health care services digitally due to the COVID-19 pandemic. However, both groups benefited from accessing mental health services digitally. This was grounded in the reduced need for geographic proximity to mental health services, as well as the improved access to other sensory flexible experiences. Financial costs proved to be the most prominent barrier to access. Lack of funding allocations also introduce an increased cost to service and equity for both groups. This supports the notion for greater government subsidies and funding resources. The usability of digital mental health tools played a large role again for both groups. We found that most digital systems lack a level of customization, and this highlights the importance for digital services to include a personalized element, one that is client-focused and also offers a sense of agency and control. Efforts to integrate personalization by practitioners, so that could include the use of inclusive language, can help build greater trust between the client and the queer client and the practitioner, which is integral to the therapeutic relationship. We also found that modern digital mental health solutions to be largely impersonal. Modern digital solutions often present the inability to properly perceive the level of client comfort. And while this was deemed a barrier by our mental health practitioners, it also makes it difficult for our queer adults to experience an enhanced feeling of self-awareness and trust. The last consideration falls onto the themes of privacy and confidentiality. Queer participants requested agency control, while our practitioners requested safeguards to not only protect themselves, but that of their clients. If we consider mobile application use by their clients, and which they may be using on their own time, their threats to data privacy are gradually increasing as well. And so practitioners who are encouraging the use of these tools with their clients should acknowledge the limits of confidentiality and encourage their clients to use these apps with caution. When it comes to mental health practitioners, training and education have various overlapping elements with the perceived comfort of using virtual reality. There is insufficient training at this time that encompasses technological onboarding, and which we also believe plays a role in the low comfort levels of using this type of technology. Beyond the technology aspect, we found that the success of the service is also dependent on 4 factors. First, the success somewhat depends on the level of clinician support and the client's willingness to participate and improve in treatment. Virtual reality mental health care tools that appropriately address personalization and privacy have the potential to help alleviate the associated fear that queer adults experience, and which may in turn encourage them to be more actively participating during treatment. Second, the success of the service needs to consider accessibility needs, particularly in the domain of cost and stigmatization. Despite the reduced cost of virtual reality equipment, their cost is still comparably higher than other video conferencing tools. However, we believe that mental health practitioners can consider adopting more cost-effective and publicly known alternatives that are commercially available, such as Google Cardboard or VR gathering tools such as Hubs by Mozilla or AltSpace VR, which we believe could be viable alternatives for future research. Third, the success of the service also depends on the principles that we've highlighted on usability and immersion. Usability principles are currently at a crossroads with the technical limitation of VR. For some, the size of the VR system itself limits their use in certain clinical settings. However, for others, the mobile VR platforms can only provide so much level of immersion. However, when immersion is present, it can certainly motivate queer adults to continuously utilize mental health care services and change their overall perception towards healthcare providers. Lastly, A successful VR-based service should focus on flexibility and crafting individualized experiences that can easily be controlled and adjusted mid-use. And this is important because it allows for a customizable digital mental health solution that can also ensure that the client's individual therapy program is built on comfort, but also on gradual progression. So this takes us to some of our considerations of our study in terms of its limitations and what we hope for future work. In terms of limitations, there were several limitations which we identified. First, barring unpredictable technical issues, we believe that our participants may have felt inclined to progress through the survey as quickly as possible, which may have resulted in our team collecting some potentially less rich data when comparing it to other qualitative methodologies which could have been used, such as interviews. Second, many of our participants had limited experience using virtual reality, while having more prominent experiences with digital tools due to the fact that the COVID-19 pandemic had shifted things mostly online. This may have contributed to an emphasis of insights and data collection with insights from digital services and less on those that are specific to virtual reality potential. Third, our survey results provide a very limited but also generalized perspective of virtual reality use and the factors influencing their adoption at a broader health system level. We believe that future work should focus on repeat evaluations in different countries and practice settings in order to compare our findings over time, but also to reach a greater number of participants with a wider variety of demographic makeup, particularly in the case of our mental health practitioners. We would also encourage research teams to consider incorporating additional research methodologies in tandems with the ones that we've used in this study, including surveys, and utilizing methodologies such as qualitative interviews, co-design sessions, or even the creation and use of a journey map, which we believe could highlight design scenarios for both queer adults and mental health practitioners, and would also provide both groups an opportunity to expand on the themes that we've identified and potentially introduce some new ideas.
We would like to thank you for taking the time to listen to our presentation on our paper, Queering eTherapy, Considerations for the Delivery of Virtual Reality Therapy with LGBTQ2IA+ communities. We encourage all of you who, with any questions or conversations, to reach out to any of the authors at their email provided below.